Hello, everyone. My name is Mardad Hariri, and we've got here Greg from Revelation Pharma. He's an expert in the subject line men's health, especially when it comes with ED and other condition that affects men after the prostate surgery. And he has a wealth of information. We're gonna just start this program and just shortly, just to let you know, this is a three-part series, and we just basically we're gonna have this today, and we're gonna do it again next Tuesday, and which is July 2nd, and then the final episode will be, or the webinar would be July 9th at the same time at 1 p.m. So if you want to go ahead and register for those future webinars, that would be great. With that said, Greg, I know we got a tight schedule and you got a
Yeah.
lot of ground to cover. So if I get other people joining, we can go ahead and let them in. Thank you, guys. I see more people joining. So thank you for joining us. And my name is Mardad Hariri. I'm a pharmacist. I've got Greg over here from Revelation Pharma. Today, he's got a very good program, and he's gonna talk about this program at the end. I'm gonna tell you a little bit about some of the telemedicine opportunities for pharmacies. And then, as I mentioned, it's a three-part series, which we'll do on July 2nd and July 9th, Greg. So with that said, Greg, go ahead. You can share your screen if you like, and
Okay.
I will, and you
Yeah.
can go ahead. Okay, go ahead,
So
Greg.
for those of you who have not been on a webinar with me before, I'll give you a brief introduction. I am a pharmacist. I've been in compounding pharmacy for a long time and working with a lot of men's health issues, erectile dysfunction, hormone therapy, um, pretty much anything sexual dysfunction, libido, uh, quality of life issues. I am the men's specialist for Revelation Pharma, which is a network of compounding pharmacies around the country. So I'm a clinical liaison. I work with physicians. I train clinics and doctors. I do private consultations with patients. I also speak for a couple of the larger support groups, especially prostate cancer support groups, Zero Cancer. I'm a national speaker for them. I work with companies like the HRT Training Academy, Boston Scientific, Berkeley Life. Um, so lots of folks that are focused on the same type of issue. And through my work, one of the things that developed was a very obvious need. Patients were not getting the kind of post-prostatectomy care they needed in terms of support for everything from incontinence to sexual function to issues with intimacy. So several years ago, I wrote and published a post-prostatectomy penile protocol. That is, you actually been working with urology clinics and patients all over the US. We do that throughout the network of Revelation pharmacies currently. Um, and it's extremely beneficial. It shows great progress and getting men back and their partners too back to where they're really enjoying quality of life. So with that being said, I'm going to share my screen. My presentation today is going to be specifically about uh, men's health and sexual dysfunction, in particular, erectile dysfunction. Hoping that you're seeing this. Dad, are you seeing my screen?
No, I don't see it. You can
Okay,
share your screen, yeah.
hold on a second.
Yep. All right, we see your screen now.
All right, excellent. So this particular, and again, it's basically an overview of erectile dysfunction. And there again, that's me. I am Greg McKettrick, pharmacist. I am the clinical liaison men's health specialist for Revelation Pharma. Here's the legal mumbo jumbo that we have to do, basically just letting you know this is not anything that is causing I'm diagnosis. I'm not curing anything that the basics in terms of that. So in terms of what this is going to cover, it is lengthy. I'll be perfectly honest with you. When I started this, it was going to be basically just on ED, but there's so much that is encompassed in erectile dysfunction that it kind of just took on a life of its own. So we're going to talk about an overview in terms of what is ED, definition wise, and then from a practical standpoint. And then what are the components of ED? So there's erectile dysfunction, premature ejaculation, delayed orgasm, delayed ejaculation, anorgasmia, performance anxiety, even Peyronie's disease plays into this. And then what are the effects? How does this impact the lives of the patients and their partners? In terms of prevalence, we'll talk about the age progression, as well as the contributing factors based off of comorbidities, so other disease states, and of course the medication therapies that go along with them. And we'll spend a good bit of time talking about some of the ones that you guys are probably familiar with, but then for those of you who are not terribly familiar with compounding, we're going to jump into a good bit that might kind of seem a little bit strange on first glance. So hopefully it'll give you some good ideas. So erectile dysfunction, what is it? If you take it by the very basics, it's inability to maintain an erection satisfactory for sexual intercourse. And then, just going into Merriam-Webster's dictionary, right behind that, they say, see impotence. And you look up impotence, what's there? That's a quality or state of being impotent. But then it says lack of power, lack of strength, lack of vigor, or weakness. And under that, it is an abnormal physical or psychological state of a male characterized by inability to engage in sexual intercourse because of failure to have or maintain an erection. And again, then referred back to erectile dysfunction. So I'm using this just to kind of set the tone of why I find this to be so important. If you look at those and then imagine a patient, imagine, your neighbor, your brother, whatever the case is, comes to you and starts talking about this, think about the fact that, here is a disease state that is really, really labeled with some very negative images. And, that's how it represents, and that's how men really feel about it. So you have to take that into consideration. So, this is why I find this to be so important. And, I get a little irritated by some of the oversimplifications that we see in, the media, advertising, even the online promotions that you see from some of these companies, because they really don't do justice to the patient. And again, like I said, when you look at this and you see the terms used in terms of defining this, it doesn't, you don't have to be a genius to figure out that it's a significant diagnosis, and it really does impact men physically, emotionally, and psychologically. So it's very, very important. And talk about prevalence. So based on current statistics, by 2025, there will be 322 million men affected with erectile dysfunction. That's a lot of patients. So I've given you Merriam-Webster, and now you're going to get from Greg's dictionary of all things guy. What is erectile dysfunction? As far as I'm concerned, this is probably about as accurate as you can be. Erectile dysfunction really means that there's an inability to confidently perform. I can't do what I want. Whether that's once in a while, all the time, whatever the case is. If it's not working the way I want it to, I got a problem. So I can't maintain a functional erection, or my erection as I would really like it to be, as I think it should. And that's really important there because that comes up later. It's the I think part. Um, Worrying about not being able to perform is huge because not only does that kind of feed into this downward spiral, but it also can cause a lot of negative issues in terms of. And then, talking to patients, how did this happen? When did it happen? Well, everything was fine until I turned a certain age. I had an injury, I had a surgery, I got started on a new medication, or I got into a new relationship. And, one of the real negative issues with this is that for a lot of men, if they have an issue, if they're not confident in their ability to perform, that bottom one right there becomes huge. So call it a defense mechanism, if you will. But, men, when they can't really perform adequately, they tend to separate themselves. So they really lose motivation, they lose the interest in sex, or at least they are not confident enough to pursue it. So they claim that they're not interested. So erectile dysfunction is obviously extremely common condition. It is age related. We definitely see the progression of ED as we age. There are significant physiological and emotional factors, um, and they're intertwined. So, look at some of the conditions that really feed into ED. First thing I'm going to tell you, and this is true for all of my consultations, when a man comes to me, any age, and he tells me that he has had a recent onset of erectile dysfunction, my first recommendation to him is that he gets to a cardiologist. Um, don't know if you've ever heard this terminology before, but there's so tight of a link between ED and heart disease due to the similarities in terms of endothelial tissue, vascular network, everything else. A lot of times we'll see ED as indication of heart disease. So we actually call it the canary in the coal mine. If you've never heard that reference, back in when we were, had guys down really working in coal mines all the time, they always had a canary with them because if there was any kind of a natural gas leak, the canary would much quicker than the alarm. Well, ED can be the signal alarm for heart disease. So we have to pay attention. So obviously cardiovascular disease, hypertension, depression is huge. And, we know about the fact that depression can cause ED, but can it lead and feed into ED? But it can also become part of this kind of self-feeding cycle. Certainly diabetes. We know with diabetes, the decline in the vascular nature and blood flow, huge issue. High cholesterol, thyroid issues. So, dealing with thyroid, dealing with hormone imbalance, huge component. Obesity is, and this is, one of the things that we see a huge shift in the time scale for onset of issues, both with hypogonadism and with ED. We see much younger men reporting, and a lot of that has to do with the increased reporting of obesity and also kind of the lifestyle that people are leading. Low testosterone, although it's not the be all end all for erectile dysfunction, it certainly is a big player. So I call it testosterone and libido factors. That's the want to that drives the can do. So certainly plays in. Even sleep disorders, because if you're not sleeping, your cortisol is messed up, and you're, again, this kind of feeds into hormone dysregulation, so you get problems with that. Another factor that plays into very early onset in terms of symptoms, substance abuse, alcohol abuse, smoking, huge issue, especially, we don't think about it too often, but opioids, huge development of ED, especially for chronic pain patients. And then, things like seizure diseases, Parkinson's, MS, these all feed in. And again, some of it has to do with neurologic response, some of it has to do with medication. So, beyond just the medical conditions, obviously age is a huge factor. Relationship problems. So stress in a relationship can be very problematic in terms of sexual performance. Anxiety, whether it's caused ED or it's feeding the ED. For society, like we talked about, from different medications and conditions. So a lot of different factors that play in there. Now, in addition to that, we also see that this aging progress is very, very well documented. In fact, it's based tell by decade of age where you're seeing the highest prevalence, and it's essentially 10% per decade of life in terms of increased reporting. So we same time we do kind of have this linear progression as we age. So diagnosis, and I will tell you flat out of the time, diagnosis is really just a formality.
Excuse me,
Because
Greg.
yes,
Can you do us a favor? Can you, on the top of your presentation, can you do a slideshow? It gets a lot bigger. Just click on slideshow on the very top of the page.
yeah, sure. Sorry about that.
And just say, I guess, set up slideshow. Or you can say on the left-hand side, from beginning, from current slide, on the left-hand side.
Okay,
Yeah, just say from current slide. There you go.
there you go.
There you
Okay,
go. Much better. Thank you.
perfect. Sorry about that. Okay, so again, as I was saying, diagnosis of erectile dysfunction is really more because for most men, it doesn't need to go through a scientific process. They know whether or not things are working. And there's a very common term, it's called the door handle question. If you talk to doctors, general practitioners, internal medicine docs, they'll tell you about the door handle question, which essentially is when you get a gentleman that comes into the office, and maybe it's to have a mole checked, or he's wants to have his blood pressure taken, whatever the case is. And as the doctor's walking out the door, the common thing is, "Hey, doc, there's one more thing I wanted to ask you." An unwillingness to lead with that issue that men kind of feel like they have to cloak that in such a way that they're embarrassed to come in and talk about it. There are physical cardiac function, checking for injury. So injury to the penile tissue, to the testicles, nerve conduction issues. Even just basic prostate exam can give a lot of information. And then you do ultrasounds checking for blood flow. You can do what's called a nocturnal tumescence test, where they're literally checking to see if there is any erectile function during the night, or what they call the hibernation. And then tests for hormones and different issues to see if there's any undiagnosed underlying conditions. Majority of the time, if you go into a urologist, they use a psychosocial history. It's called a health inventory for men. And it's a fairly comprehensive questionnaire that goes through and asks all kinds of questions about sexual function, ability to perform. And it's rated on a scale. So if there's 25 points to the test and you score 22 to 25, well, you really don't have ED. 17 to 21, you have mild ED. 8 to 16, now we're getting into moderate erectile dysfunction, and 1 to 7, um, that's severe ED. So basically, it's asking what your performance capacity is, and you're saying it's very poor. And as we've talked about before, age, you're going to see a decline in the shim test as well. So here are some more in terms of erectile dysfunction and the components. Like I mentioned, there's so much involved in it that we really have to have a perspective, because just talking about ED doesn't do it justice. So erectile dysfunction in general, inability to achieve or maintain an erection satisfactory for sexual activity. We'll just use that as our baseline. Prevalence of ED has increased 111% since 1995, or 170 million cases. Now, in that, keep in mind that the little blue pill did come out. So there's a lot of guys who are reporting who probably were not prior to the availability of Viagra, simply because they didn't really think there was anything that they could do about it. And now it's all over social media, it's all over TV, and every movie, even music videos. So it's becoming much more common. So I think part of that is, it really a disease progression? Yeah, I'm sure it is to a degree, but I think there's also the fact that there's probably a much higher percent reporting. Premature ejaculation, which a lot of people may not necessarily consider this part of ED, but hey, if you really say that erectile dysfunction means that you're just not satisfied with what's going on, then this becomes a huge factor. And to be perfectly honest, it's the most common sexual dysfunction in men, up to as many as 75% of men. And this really depends on the criteria. This depends on how it's being measured, but there are again some standard units of measure. The baseline of this is called the IELT, or intravaginal ejaculatory latency time, and this basically means how quickly do you orgasm after penetration. So there's existing diagnostics like the IELT, but this actually omits a percentage of the population, men who ejaculate, they climax without any penetration. A lot of that can be psychological, it can be emotional, and there can be some actual naturally occurring is a hereditary condition. There's also a difference between what's considered a lifelong or acquired PE. There's also a difference between objective and subjective, or subjective meaning, what the PE. So whether or not this is something that has happened throughout the entire course of life, and it's a genetic condition, it's a neurologic condition, or this has been an acquired condition that developed to particular hormone levels, or a psychological condition. So objective premature ejaculation based off of the IELT. So to ejaculate for men, it's actually 5.5 minutes. So this is where this subjective stuff plays in, guys, because a lot of people just, they think 5.5 minutes isn't long enough, even though that's really average across the board. So they do have definitions as far as the IELT, some being really, really very specific. So, ejaculation occurs in less than 2 minutes, at least half the time. In cases of very, very severe premature ejaculation, within 15 seconds of penetration, getting into kind of the more moderate, where it's a minute to 2 minutes. So again, some of these are static measures versus the subjective. So again, when we're talking with patients, more often than not, we're dealing with their subjective or their relational PE, what they think. So in real world terms of this, we would look at a definition that's more like you are ejaculating quicker than you and your partner are comfortable with, or the premature ejaculation is causing emotional, psychological, relationship distress. In other words, if it happens too quick, it bothers you, that means it's an issue. So the cases where the ejaculation occurs prior to activity, this is somebody just gets worked up so much that they can't even have sexual contact. A lot of times this is getting into a emotional, psychological, sometimes a genetic disorder, and it's a little bit deeper dive than what we can get into on this patient. So again, kind of coming back now, looking at just ED in general. So ED can be defined as the inability to maintain an erection long enough, period. But they have a lot of causes, whether it has to do with blood flow, neurologic issues, certainly, like we mentioned, psychological, and then lots of other health conditions. The most common form of ED is vascular. Just means that the blood flow is not sufficient to maintain penile in the blood vessels, into narrowing of the blood vessels, or that the valves have started to lose their ability to maintain. But again, flow is the biggest issue. Neurogenic, due to nerve problems, whether this is stemming from the brain, the ability to initiate the erectile cascade out of the hypothalamus. It may be due to an injury, whether that's a spinal cord injury, pelvic or prostate injury or surgery, perhaps radiation for a form of cancer like a prostate cancer, something like stroke even, or MS. So a lot of different conditions can play in. Hormonal, as mentioned, so whether it's simply a testosterone deficiency leading into it, or more of an endocrine imbalance or dysfunction. So these are things that can be addressed, and this is why you want to do really thorough intake of patients so you have a good picture of what's going on. Psychogenic, and this is where, boy, a lot of this stuff kind of falls down. This is the catch-all, because this is where we get this negative feedback loop. Once there are negative thoughts, once you have performance anxiety, once you're afraid of what kind of performance you're going to have, that can cause huge issues. Is that initiated due to depression or psychological condition? Does it feed into it? Is it due to work or relationship anxiety or stress? Or is the ED the thing that's causing the stress? But again, it's this kind of never-ending loop. So it's really, really important, and it's something that again can be very difficult from pharmacist position to providers. We're looking at a patient's history and then seeing what they've used in the past that had benefits for them. And then medication induced. This is very common. Antidepressant medications, we know. Blood pressure medications, we know. Opioids, like I mentioned, even amphetamines, and then street drugs, all have the implications in terms of leading to or causing ED. So now we know what it is. What do we do about it? So again, like we, there is so much ED being reported at earlier ages has a lot to do with lifestyle. So, you know, modifying that lifestyle can be extremely beneficial, whether that be, you know, diet and exercise, quitting smoking, alcohol or substances. And in some cases, it may have to do with actually seeing a counselor, depending on the origin of the disorder. Supplements are still a very important part of this. And, you know, there's a lot of great supplements out there that are very beneficial. Things like ashwagandha, honey goatweed, tribulus, uh, nettle seeds. These can be very beneficial for erectile function. But like I mentioned, one of the biggest factors that feeds into the vascular nature, the blood flow. So something I lean on tremendously are nitric oxide supplements. And, you know, the main reason is, you know, our system really needs nitric oxide. And like so many other things, as we age, nitric oxide levels diminish significantly. By age 40, nitric oxide by age 60 is down to about 15%. Now you think about the age where most men start reporting issues with erectile function, and they fall into that window. So there's a strong connection between nitric oxide level in terms of the performance of the endothelial tissue, the vasodilation to allow for blood flow. So we have to have it. You know, the blood vessels are really cause the relaxations caused by the cyclic GMP, but you know the nitric oxide is a necessary. Um, so as we kind of work this together, we can really benefit patients by getting them on good nitric oxide supplements. And there's a lot of different ones out there. You know, there's the amino acid products that are like your L-arginine and citrulline, and then the diet beets, potassium nitrate, spinach, arugulas, you know, those types of compounds. Um, there is some difference in terms of the demographics of what works best. The amino acid products up to about age can be pretty effective. They go off simply because they have to go through the nitric oxide synthesis pathway for conversion into systemic nitrate. And that pathway with age, so you know, giving them something that is systemic nitric oxide isn't great. But if they're 30 or 35 years old, no problem. You know, send them up to GNC or over to your shelf where you've got that L-arginine product and let them go. But as they age, using a diet is going to be more beneficial. Life is a good dietary. Approved Medical Solutions has a good dietary. Neo 40, there's a bunch of them, but they rely again more on this natural pathway, using the nitrate rich ingredients. How to eat better, eat more greens, eat more beets, eat arugula, spinach. But if your patients are anything like mine, they're going to look at you like you got a third eye growing out of your forehead. Oh, you might be better off just pointing them in the direction of a good supplement. Again, as I mentioned, you know, a lot of the reporting that increasing as of 1995, not terribly surprising since, you know, Viagra is going on 30 years that it's been on the market now. So prior to that, and you know, I've been around long enough, I remember filling prescriptions for ED. Many of you may not have, but it's still out there and it's still pretty effective. But other herbs can really help, and they actually can mimic the effects of the PDE5s. So, you know, having a good selection of herbal remedies, or good combination product that incorporates these, can be extremely beneficial because a lot of guys don't want to go on prescription. there's still a stigma to going on prescription drugs for erectile function. So if you can get them there using things like nitric oxide, ashwagandha, yohimbine, plus the basics, the vitamin D, vitamin C, vitamin E, they're also necessary for good erectile function. So here we go, the advent of the blue pill. Viagra was actually really kind of discovered by accident, and they were actually researching. Pfizer was researching a drug for pulmonary hypertension, and they thought that if they inhibited the PDE5 enzyme, allowing for dilation of the this would be a great pathway to treating hypertension. They knew that the nitric oxide was very functional. I mean, there's been Nobel Prizes awarded for the effects of nitric oxide on cardiac function. So they figured they could do good by bringing this out. But of course, the clinical trials, other evidence popped up. Aha, right? Forget my pun. But literally and truly, the men that were in these studies were walking around with erections. So, yeah, they did patent Revasio for pulmonary hypertension, but they also patented Viagra. So that was the first to market, and that came out in 98. And then following that, we had Tadalafil and Vardenafil, and then most recent. In general, these drugs, the PDE5 inhibitors, they block the degradation of that cyclic GMP, which is necessary to sustain vasodilation. So they enhance the duration of activity, and that allows us to maintain erections. Now, here's a couple little caveats. Of course, they talk about the blue hue with Viagra, but there are also some significant issues. There's been cases of PDE5s, visual impairment or blindness. So it's very important, if you do get into a situation where your patients are complaining of visual symptoms, that you refer them to an ophthalmologist, because there are some of them are diseases that were just underlying, that they didn't know they had developmental. But again, big idea is don't cause harm. So if there's a report of any vision issues, get your patients to be checked out. Yeah, let's go through quickly. I'm not going to spend a whole lot of time on this because I think most everybody does know. But sildenafil was the first. The Revasio is at 20 milligram. And of course, we had that generic sildenafil on the market way before we had any of the generic Viagra strengths. Onset of action, relatively quick, 30 to 60 minutes. Typically, the duration of actions in that. It's best to take activity, but it is really important that it's taken on an empty stomach. So, this is still almost 30 years later. We're still talking to patients, and the first thing they tell you is nobody ever told me. So really important. Make are aware of that, because nobody wants to go out to dinner and then pop a Viagra and be disappointed. Cialis or Tadalafil. This is more selective. It came out after Viagra. Cialis is the duration of action. I love it as a once a day drug, because being able to give this, it accumulates in the system, and it really builds on the ability to have spontaneous erections. So onset of action, yeah, it is. However, I always take this several hours in advance. I cannot tell you how many guys I've talked with where they took it at 9 o'clock at night, and they report that their erection, they couldn't get an erection until 2 o'clock in the morning. It takes longer to get in the system, to have more lead time for it. So important. The PRN doses, 10 and 20 milligrams. Again, give plenty of lead time. The daily doses, usually it's the 2.5 or 5. I do see some 10 milligram daily doses. Higher doses taken frequently do really increase the side effect profile. See a lot of heartburn with Cialis. I've actually had patients report to the emergency room thinking they're of heart attacks. So make sure you're counseling properly on the use, especially the higher doses. Vardenafil, Levitra, and Staxin, side effect profile, so it's more selective than what we had with either the Viagra or the Cialis. The Staxin is the oral disintegrating tablet, so you avoid any issues with interference from stomach content. It is a drug like Viagra. And again, because it has a lower side effect profile, a lot of times this will be a go-to for guys who've had issues with some of the other PDE5s. Avanafil, love it. As a compounding pharmacist, I actually compound with yet. As soon as it's available, we will. So there's no generic out there on the market just yet. It does have a reported even faster onset of action. Heated by stomach content. And again, it is more selective than even the Levitra Vardenafil, so lower side effect profile. Oh, in general, these PDE5s, they're very effective for a large percentage of men. It does tend to vary in terms of effectiveness based on the cause of the ED. So if the cause, then there can be problems. They don't have good blood flow. These medications, it's still going to have some issues going. Men who do have decent blood flow, they can be successful in up to 80% of the cases. And this is similar in terms of pretty much any PDE5. Good reason to incorporate nitric oxide, again, with PDE5s to really support the circulatory function. Again, the typically most miscommunicated issue has to do with stomach content. Biggest reason for failure in the majority of men. Oral dosage forms, you have to take it on an empty stomach in most cases, so timing is very important. The other thing to keep in mind with any oral dosage form, this is going through first pass metabolism. So not only do you have interference from stomach content of that drug before it ever gets to the bloodstream. And this is one of the reasons why I talk to guys so frequently about the compounded versions or the ODT types. The sublingual versions of the PDE5s, they bypass the gut, they bypass first pass metabolism. So the gummies or troches or ODTs or RDTs that dissolve and they're absorbed in the oral mucosa. And it really significantly increases the onset of action. Conservatively, 50 to 65% fast as an oral tablet. Now, to dinner and use this because it doesn't interfere, the stomach content doesn't interfere with it. The other really neat thing is with compounded versions, you're not limited. It's not like you're buying Viagra. You can combine these things. You can put different APIs into a single to achieve different from the drug. This is just a sample of some of the things that we do in terms of the sublingual troches. If you've never worked with compounding, some of these numbers are going to look really funky, but keep in mind one troche can be a gummy and it dissolves under the tongue. So using a sildenafil, using even half of one of this is 150 milligram troche, half of that is 75 milligrams. But keep in mind, there's no first pass metabolism. So first pass, this 75 milligram of sublingual dose actually has higher bioavailability than that 100 milligram oral. And the same kind of a thing goes for, tadalafil. You see here what the doses are. You can do it troches using the neat thing about this, again, onset of action anywhere from 2 to 4 times as fast as the tablet. So much quicker, much shorter lead time prior to activity. Plus, you can go out to dinner and enjoy it. We get into some of these neat little tricks like combining these things. So here you see sildenafil and tadalafil. Well, that's crazy, right? Why would you do that? Well, the reason is that the sildenafil is very rapid acting and it gets into the system quickly, where that tadalafil acting doesn't get in as quick, but it stays there for a day and a half. So now you've got a single dosage form that literally, somebody can have sexual performance for a majority of a weekend from the one dosage form. Similarly, the vardenafil and tadalafil. So if they get side effects from sildenafil, we'll give them vardenafil instead. But it basically gives benefit in terms of rapid onset and then that extended duration. Now we can get into the real crazy stuff, putting our mad scientist hat on. Adding a drug like apomorphine, which if you're not familiar with it, apomorphine is a D2 agonist. So it's actually working brain. This is where we have the stimulation, the initiation of the erectile cascade. So think of it, this is tipping that first domino in terms of causing the erection. In addition to that, it is a dopamine agonist. And dopamine with this, one, independently, it can generate the erection in combination with one or two PDE5s. Then you can actually come at this issue from multiple angles. So you're getting the initiation plus the support from the PDE5. And some of this stuff is really cool when you start working with it. And you can offer patients solutions that they just never heard of. Other sublingual combinations, and again, stuff that you just probably have never thought of. Sublingual testosterone is a terrible form of dose for somebody who's going on testosterone replacement therapy, because especially for a man, they probably have to use 4 different doses throughout the course of a day. Women with sublingual a lot of times will get away with 1, but for guys, no, they're going to metabolize it out and you're not going to have it. It really doesn't work for that. But for date night, for getting a boost of energy, for getting a boost of libido, sublingual testosterone is phenomenal. It's in the system very quickly and then it's metabolized out very quickly. So again, there's no depot effect. It's term effect from taking. It's and drive and boost that libido. Again, the want to, right? Oxytocin is another really cool one. Oxytocin, they call it the cuddle hormone, right? So when a baby is breastfeeding, there's a release of oxytocin. It really causes the bond between mother and child. Well, it's not just with babies. It's also the feel good between couples. So this really is involved in all aspects of sexual activity. It helps with erectile function. It is critical and crucial for orgasmic function or ejaculation. And then overall sexual satisfaction and the feelings of closeness. So again, this is a rapid onset medicine. Gets into the system quickly and it gets burns out of the system quickly. So we typically will use this either as a nasal spray or in a sublingual dosage form, but not in the troche. Troches, it's a heat process. You have to melt that troche base to make it, and oxytocin is extremely sensitive to temperature. So again, nasal spray or sublingual suspension are great. We can do it in a oral disintegrating tablet using a press, but again, it is a super additive. And now think, okay, PDE5, apomorphine, testosterone, oxytocin, put it all together. And well, what a cocktail that is for sexual function and libido. There was this bottom line here. This is a compound that I use frequently with my patients. Men use half of a milliliter, which that dose is 20 milligrams of vardenafil, 100 units of oxy, and 4 milligrams of apo. For women, we use half of that. So 10, 50, 2. But again, drives circulatory function, erectile function, orgasmic function, libido, the whole 9 yards. So it's really a wonderful combo. Um, Talking about some other therapies here. I think we can probably, you want to hold off from here and get into this next time you're done?
Yeah, I think this may be a good place to rest or pause a little bit
Yeah.
until next Tuesday. I hope that every one of you have really enjoyed. I know I learned one or two things which I had no idea about, some of the treatments and diagnoses and things like that. So uh, it might be a good place to pause. We will send you all a link for next week's webinar. I hope you come back and join us, because there's a lot more. I mean, I think next week program is going to be a lot more detail into ways that you guys can help your patients and those who are needing assistance in their sexual health. So thank you, Greg. This
Absolutely.
was awesome. As always, it's really informative. And if anybody has any questions, you can put that in the chat right now. And if you don't, you can just maybe next week when you come in, you can just ask those questions. I was going to ask you, Greg, these PowerPoints, is that a place that maybe we can, somebody asked, can we get a copy of the PowerPoint?
Yeah, I can send you, I believe I sent you a copy. So you should already actually have a copy.
Are we allowed to pass it out to pharmacists?
Sure.
Okay, just wanted to get the permission, you know?
Well, I mean, this is something that I do with Revelation, but the bottom line is we try to get this information out. Um, you know, my intent is to let people know that's something that they can do themselves, or something they would want to partner with a compounder to really achieve. But either way, yeah, we want to make sure that this is information that's readily available.
Yeah, so if anybody needs a copy, just send us a email or call us, and we'll be more than happy to send that to you. Thank you, Greg. I certainly enjoyed it. I'm sure everybody else did. We'll talk to you next week. Thank you.
Great.
Thanks for
Thanks,
all your
guys.
time and expertise.
All right.
Thank you. Bye-bye.
Bye-bye.